For those of you on the phone, you should be able to see the first slide, and we'll get started here in 2 minutes. We're just waiting for a couple other people to join. Okay, everyone, we're going to go ahead and get started. Thank you all for joining today. I'm Elizabeth Mills, the Psychology Digital Solutions Specialist from Macmillan, and we are very excited to have Bob Julien here with us today as well. As many of you know, Dr. Julien received his MS and PhD in pharmacology from the University of Washington and his medical degree from the University of California at Irvine. Formerly an associate professor of pharmacology and anesthesiology at Oregon Health Science University. Dr. Julien has retired from the practice of anesthesiology and is currently a psychopharmacology consultant in Portland, Oregon. Dr. Julien is a nationally recognized speaker and an expert in psychopharmacology. Now in its 40th edition, Dr. Julien's Primer of Drug Action keeps pace with one of the most dynamic fields of scientific inquiry, giving students immediate access to most current research and promising new directions in psychopharmacology. Even though you are all on mute, I hope you're as excited as I am to have Bob with us today as part one of this series. I'm going to go through a few WebEx items and then pass the roll over to Bob. So all of you have already joined on the WebEx. If you have any trouble with your audio, I'm going to just give you a quick rundown on what you can do. To see here, you can go on and dial in from your headset if need be. So the number is here. If you're unable to hear this but perhaps see the screen, you could dial in there. Also, you all are on mute, as you've probably already figured out. If you have a question, you can simply click on that chat icon at the top of your screen and type a question here. You can either send it to me and we'll answer questions at the end, or send it to Bob and myself and we'll answer them again at the end. So feel free to chat your questions there on your WebEx screen. I'm going to go ahead and hand it over to Bob.
Good morning. Hopefully I have control. I don't see control here
You will in
yet.
1 minute.
Okay. Do I click share my desktop?
Yep, go ahead.
Okay. So now I just need to have the slides come up. Where's the first slide? Where is the slide set?
I believe you have them on your desktop, is that right?
No, it says thanks for using WebEx.
And I believe you had your slides saved to the desktop?
Ah, that's where I go to get them then. Okay. Hang with me a minute. I'm going to have to go to my desktop and pull the slides because I thought you had them. Here we are. And hopefully they're coming up to you. Now, can you see that?
Yep, we can see them.
Okay. Sorry about the delay there. Well, this is Bob Julien, and on behalf of Claire Advocate and Joe Camati, I invite you to an overview of our chapter, which is chapter 12 in the recent edition, on antidepressants. I title it 6 Decades of Continuing Progress. And basically, for about 50 or almost 60 years, the industry has tried to get us to prescribe antidepressant drugs for the treatment of depression. Also for the treatment of anxiety, and indeed these drugs may be more anxiolytic than they are antidepressant, but to basically improve the lives of people with debilitating depression. The question we've been fighting with probably since about 1955, when the tricyclics and the MAO inhibitors came on the market, is do these drugs alleviate depression? And in general, if you look at a graph of the intake scores of the Hamilton Depression Rating Scale with the improvements with drug therapy, you find that the effects are modest at best, and indeed at mild to moderate depression, these drugs are not of great efficacy, and it's only when you get into more severe depression that you can get really demonstrable changes. That's the data. But people do think these drugs help. In general, they are not terribly effective in mild to moderate depression. Your therapies, psychological therapies, are better or equally good, and they are better in combination. Well, what are our theories of depression? If you go back to the mid to late 1950s, we had a drug called Reserpine, and you might look that up in the literature. Reserpine is an antihypertensive drug, was also used as an antipsychotic drug in the 1950s, and it was found that patients who take Reserpine would become depleted of their catecholamines, epinephrine, norepinephrine, and serotonin, and also dopamine. And on the other hand, patients who use the amphetamines, drugs like methamphetamine, things like this, they became manic. So we developed basically the catecholamine hypothesis of mania and depression. That persisted until perhaps the 1990s when we got Prozac, the first of the 6 or so SSRIs, serotonin-specific reuptake inhibitors, and found that these drugs had some antidepressant properties, and the theory switched to a serotonin theory. This is changing now and has largely changed into the neurogenic theory of depression. Be a great place to have your students do some literature searching in what is this theory. And basically the concept is that existing neurons become sick in depression, and with antidepressant, either medication or psychotherapeutic options, these neurons can repair or remodel themselves. There's also a neurotropic factor where the brain is capable of making new neurons. I remember at one time learning part of the old way of doing drug education, that you're born with all the brain cells you're ever going to have. Bob, you better not drink or smoke dope because you're going to kill off some neurons and you're going to be a dunce. Well, that's wrong. We now know that there is a process of neurogenesis where there's a constant turnover of neurons. And in depression, in depression, we find that, going up a slide, that neurogenesis is impaired and that the brain actually shrinks to a degree. So a variety of stimuli can damage neurons, decrease neurogenesis. For example, even using methamphetamine or the newer drugs such as bath salt drugs, MDMA, that they can alter the cocaine, they can all alter the blood-brain barrier, allow oxygen-reactive species into the brain, and can damage especially serotonin and dopamine nerve terminals, and long-term depression is a result of that. We now know that our antidepressant drugs repair neurons and increase neurogenesis. BDNF, or brain-derived neurotropic factor, is one of the major players in this area, although there are more. I think our textbook, and this is in pages 387, which carries through to 391, gives lots of references for this to get your student into the literature. I think it's vital to read some of these papers, especially the reviews, not only on how drugs do this, but also on how non-drug therapies will do this. But let's look at our evolution of antidepressant drug therapy. Back in the mid-50s, as I said, we had the tricyclic antidepressants. I used to think a tricyclic was a Italian bicycle, but the MAOIs. And indeed, of all antidepressants, even today, the MonoAmineOxidase Inhibitors are probably the single most effective antidepressant drugs. And we'll talk about that in a little bit, and when we talk about the selegiline skin patch, which is extremely effective. It wasn't then until the 1990s, I think it was 89, that Prozac came out, that the SSRIs came out. A depletion of serotonin was demonstrated, and the antidepressant properties were claimed. In between that, between about 1960 and 1990, we had a variety of kind of oddball antidepressants that came out, which I call atypical antidepressants, things like Bupropion, Welbutrin, that we'll talk about in a few minutes. From the late 90s through the early part of the 2000s, we got the dual-action antidepressants. Actually, the tricyclics were the first dual-action antidepressant, but ones that are advertised on television today came out as dual-action antidepressants. These were serotonin and norepinephrine reuptake blockers, and they were promoted both for treatment of depression and for the treatment of anxiety. And finally, more recently, we've been looking at a selective norepinephrine reuptake inhibitor, SNRIs, specific norepinephrine reuptake inhibitor, of which the prototype we'll talk about is actually an anti-ADHD drug, but it also has antidepressant properties. Well, let's go through these. Our first generation antidepressants, the tricyclics. And here's a list of the drug, 2, 4, 6, 7 of them still on the market, still quite widely used. These drugs are our original dual-action drugs. They block the presynaptic reuptake of norepinephrine and serotonin. That's where the dual-action come from. But they have significant side effects. These drugs can be cardiotoxic and fatal. I remember in my internship days sitting at night by the bed of the overdosed patients waiting for them to have cardiac arrest so we could cardiovert them. It was kind of a lousy job. But these drugs we find are antidepressant, they're anxiolytic, and they're analgesic. Those are the three hallmark actions. They're also sedating, and this is especially for patients with depression, anxiety, insomnia, and chronic pain. Indeed, the tricyclics today have a very, very important role in the treatment of chronic pain syndromes. Certainly in chronic pain, you see depression, you see anxiety, and you need analgesia, and sleep problems are a big issue, and tricyclics can be beneficial in all of these. They are my second tier of analgesic medication. The first tier are anti-inflammatory drugs like Advil. The second tier is a tricyclic antidepressant. The third tier that we'll talk about on Wednesday are the anticonvulsants. And then the fourth tier, used only when all of these have been optimized, actually is to go to an opioid drug. Unfortunately, we tend to forget these first tiers today, and patients who complain of pain are placed on opioids, and that is really not very good medicine. Tricyclics, as we said, block norepinephrine and serotonin reuptake. The norepinephrine reuptake gives you the analgesic effects. Serotonin would be anxiolytic and antidepressant. They also block histaminic and cholinergic receptors. So they're antihistaminic and anticholinergic. And because of this, you get sedation. That's from the antihistamine, like Benadryl. Cognitive dysfunction and delirium, and that comes from the anticholinergic effects. And to get into this, I would urge you to look at the pharmacology of scopolamine, which is the prototype anticholinergic drug. We used to use it as a preoperative medication to induce amnesia, so they didn't even remember coming down to the operating room. And you also can see delirium and out-of-body experiences. In fact, I might suggest you look up anticholinergic or scopolamine and Halloween, because this underlies the whole holiday of Halloween with cognitive dysfunction, out-of-body experiences, and delirium. And indeed, Witch's Brew was a scopolamine brew. These drugs are contraindicated in the young because we do not want the cognitive dysfunction in the young, and the same goes for the elderly. Some would ask whether they should be used for anybody in between, but I think the use today shows they can be used judiciously. They should be taken at night because of the sedation, and you need to constantly monitor for cognitive functioning and any signs of delirium. You stop the drug and those are reversible and go away. So you have to be very careful about the cognitive dysfunction and the delirium, as we said. Beware of Silenor, which is a way for industry to get us to spend more money than we need to for our medications. It's a remarketing of Doxepin that came at doses as low as 10 milligrams. Doxepin comes in 3 milligram and 6 milligram doses, and they charge about 50 times more for it. It's meant as a sleep promoter to take it at bedtime. You're probably better off giving a 10 milligram capsule of something like Doxepin, and if you have to, open the capsule and dump half of it out. And it's $2 a month versus $214 a month. Well, after the tricyclics, and we haven't yet discussed the MAO inhibitors, these were our atypical antidepressants, called so because they were different in effect, different in structure, and they were intermediate drugs before the SSRIs came out. Trazodone is the first of those, very widely used today, and I think it's appropriately used. Drowsiness is a side effect, and the drug is antidepressant. It's administered at bedtime because of the drowsiness, and it can be an effective sleeper without causing blackout like we see with the Ambien tragedy. And maybe we'll discuss Ambien in a future lecture. Trazodone being a tricyclic, this one is slightly less anticholinergic, and there does not appear to be a lot of cognitive dysfunction with it. Priapism is the main side effect. It's prolonged and painful erections in males. I've only seen one case in a 25-year practice of anesthesia. It's really quite rare, but one needs to be advised that it can occur, and they should report that and stop the drug if that does occur. There's a new form of Trazodone called Trazodone ER under the trade name Eleptro. It may be too much of a dose. It may have more hangover, and it's much more expensive than generic Trazodone. So I do not recommend this form of the drug. Basically, just plain old generic Trazodone is just fine. The second of these atypical drugs is Bupropion, or Welbutrin. If used for smoking cessation, it's marketed under the trade name Zyban. This is a dopamine reuptake inhibitor, also has some norepinephrine reuptake inhibition. So the drug actually is analgesic to a degree. It's not widely used for that, but it can be. The dopamine reuptake inhibition is the same mechanism of action as cocaine. Cocaine does the same thing. and it has an anti-craving action, and this underlies its use in smoking cessation treatment. Well, if this is a drug with a mechanism like cocaine, would you expect this drug to be anxiolytic, such as the tricyclics? Well, the answer here obviously is no. Side effects include anxiety, restlessness, tremor, and insomnia. The drug is effective to treat depression. It has been tried in ADHD, but it's not commonly used for that, although I've seen it used in adult ADHD and nicotine dependency. In contrast to the SSRIs, this drug can actually improve sexual functioning rather than depress it. We'll get there in a little bit. But much of the increased use of Bupropion has been in patients who suffer the sexual side effects of the SSRIs. The really important point with Welbutrin is that one must constantly monitor for worsening anxiety or even de novo generation of anxiety disorders such as panic disorder. In my psychopharm practice, much of it being legal or forensic, I find that very often a patient will come in complaining of anxiety. It's not noted that they're on Welbutrin, or it's not tied together. And so what commonly happens is I then see a prescription for a benzodiazepine to treat the anxiety caused by Welbutrin. And anytime you use a second drug to treat the side effects of the first drug, now you're in problem. So constant monitoring for worsening anxiety is important with Welbutrin, and patients on Welbutrin should always be asked about anxiety disorders. So any drug that increases dopamine can cause or worsen anxiety and compulsive disorders such as OCD. This would apply to Welbutrin, to varenicline for smoking cessation, to drugs like Mirapex and Requipt that are used for restless leg syndrome, and also to drugs like Sinemet that are used for Parkinson's disease. So anytime you see anxiety, always look for contributions of medication to these anxiety disorders. I was involved in a court case once of a middle-aged woman who developed OCD that became quite severe. It then led over time to increased gambling and a gambling compulsive disorder. Her friends took her back to her doc, who put her on an anxiolytic drug, which then depressed her cognitive functioning. As it turned, and she had actually been put on Mirapex, and it ended up with her embezzling $250,000 from her employer. She was caught. She was convicted. She went into jail. They took her off her Mirapex and also off of her cognitive inhibitor, and she returned to normal. All this went away. Her cognition came back. Her compulsions went away. I explained this to the judge at the sentencing hearing, and she said, I refuse to send this lady to jail because it was all caused by her doctor. You know, these things do happen, and if you know a bit of pharmacology, even if you're a non-prescriber, such as a psychologist treating these people, you can avoid some real disasters if you know some of these basic principles. Effexor then came out. This was our second dual-action drug, like the tricyclics, inhibits norepinephrine and serotonin reuptake. It is not really anticholinergic or antihistaminic. Therefore, it's less cognitive dysfunction, less sedation. And Effexor ER was approved for the treatment of GAD. And I think this was the first time an antidepressant had been approved for an anxiety disorder. I thought it would be a pretty darn good drug. I've changed my mind in that over the last few years. The most important thing being that this drug can cause manic flips or homicidality compared with other antidepressants. I've had several legal cases involving this where patients with bipolar disorder have done really horrible things under the influence of venlafaxine. This started around 2005 when we had medications for monopolar depression. We had drugs to calm bipolar disorder, and we then found that about 80% of the time patients with bipolar are actually in depression. And so concern came of whether by giving an antidepressant you could flip somebody from depression into mania. Large studies were done. Surprisingly, Welbutrin was found to be one of the least likely to do this. SSRIs were fairly neutral, and of all of them, venlafaxine increased the incidence of manic flips. I've been involved in a couple homicides in patients who were in manic flip from venlafaxine and actually committed murders. And if you go on Google and type in venlafaxine and homicidality or manic flips, you'll find large literatures. You'll find much less of this in medical literature that you would find on PubMed. Emsley did a study a long time ago, back in 2007, and found that it was ineffective in child and adolescent depression and was associated with the highest rate of suicidal-related behaviors. And this is probably due to underlying bipolar depression in these persons. We'll talk about the treatment of bipolar depression, I believe, on Friday when we cover the atypical antipsychotics. Emsley said that this drug was relatively contraindicated in people under 18 years of age. Venlafaxine has been tried in ADHD, 5 studies, and the drug is a very secondary drug. It is much less effective than methylphenidate. The Tortia trial, which stands for Treatment of Resistant Depression in Adolescents, was a large study looking at the effects of an SSRI, cognitive behavioral therapy, or Effexor with and without CBT, and found that adding CBT was better than a medication switch. We'll talk more about that later. But venlafaxine was associated with the greatest incidence of adverse side effects. And this study limitation was it did not merely evaluate adding CBT to the original SSRI. Well, we had a problem with venlafaxine. The patent was running out back in 2008. So what was this poor drug company going to do to make huge profits when the drug went generic? Well, the company was pretty smart. They looked at the active metabolite of venlafaxine, which was called desmethylvenlafaxine. The name was changed to desvenlafaxine. And indeed, venlafaxine is metabolized by 2D6 enzymes to this desmethylvenlafaxine, which is also a serotonin norepinephrine reuptake inhibitor. And it has much of the same action as does venlafaxine. Essentially, the emperor's new clothes. If somebody is a poor metabolizer of venlafaxine, and if we have some time for questions at the end, we can discuss how you might determine this. Genelex Labs in Seattle has a really good study protocol to look at your ability to metabolize antidepressants and other psychoactive drugs. Those people, perhaps it's reasonable, but just to prescribe an expensive press stick only makes money for the company. It's probably no better than venlafaxine. Okay, These were the intermediate drugs. Then in the very late 1980s and through the 90s, we got the SSRIs. These drugs block serotonin reuptake. As you know, action potential comes down, the axon releases serotonin, it does the backstroke across the synaptic cleft, activates postsynaptic receptors, and the action is terminated by active reuptake into the postsynaptic vesicles. I divide the many postsynaptic serotonin receptors into three types, basically for teaching purposes. The serotonin 1 receptors are antidepressant and anxiolytic. Activation of serotonin 2 gives you the insomnia. As you know, even though these are sedatives, some people have sleep problems with them. The anxiety, the agitation, and the sexual dysfunction. Activation of serotonin 3 gives you the nausea. Well, what would be a really good antidepressant if you work off of this? Certainly a drug that blocks the serotonin 1 receptors would be ideal, or we can have a drug that stimulates serotonin 1s and blocks 2s and 3s, and we'll talk about those here in just a minute. We now have about 6 SSRIs, fluoxetine, sertraline, paroxetine, fluvoxamine, citalopram, and escitalopram, and we'll take a brief look at those 6. First, however, there's 2 things to cover. The first is serotonin syndrome. This is a case where the blood levels of the drug are too high, and you get an exaggerated response. Classically, these people are hauled into the ER because they're just out of it, they're losing it, they're disoriented, confused, hypomanic, delusional, may represent a manic flip, I'm not really sure. Stop the drug, usually 24 hours, half the drug will be gone, and they're improved. They're agitated, they're restless, they have autonomic signs, neuromuscular signs, etc. Usually this resolves. I don't see a lot of serotonin syndrome in my practice. Although what happens is when a benzodiazepine is added, because these people are agitated, we find that benzodiazepines slow the metabolism of the SSRI, and it results in drug accumulation and increased toxicity of the SSRI. Interestingly, most of the SSRIs inhibit the metabolism of the benzodiazepine, increasing sedation and cognitive impairments. Drug interactions from enzyme inhibition are really rather marked, and they're very important in the case of SSRIs. The second thing is serotonin withdrawal syndrome. And this is it can be very debilitating, very difficult to withdraw a patient from. I remember one young woman who said she had been addicted to 2 classes of drugs in her life, or 2 drugs. One was heroin, and the other was Paxil. She said the heroin was no problem to come off, but she will never again try to come off her Paxil. Gets incredible sensory disturbances, paresthesias, electrical shocks going down her arms and her leg, out her hands, out her feet, horrible headaches with the whole top of her head feeling like it's just coming off. Also severe flu-like symptoms, GI symptoms, and also disequilibrium. Vivid dreams and insomnia are very marked. It's a nasty, nasty syndrome to come off, and we can talk about treatment of that as much as we can here in a few minutes. Okay, there are some specific SSRIs. I divide them into 5 different classes, and we'll cover that right now. Fluoxetine, the important thing in fluoxetine is the drug has long half-lives, about 2 to 4 days for fluoxetine. The active metabolite is norfluoxetine. The half-life is about 2 weeks. It can take about 3 months to really eliminate all the fluoxetine in your body. This is kind of a nice way to withdraw a patient from shorter-acting SSRIs you can switch them to fluoxetine, and they will the blood levels will drop over a period of 2 or 3 months. It's also a way that I recommend treating depression during pregnancy. These drugs are not teratogenic. A patient who's on, let's say, Celexa with a short half-life can be switched as soon as you know she's pregnant to fluoxetine. Stop your fluoxetine around 7th or 8th month and let the infant and the mom detox. You're letting the infant detox in utero, and then after delivery, mom can be restarted on whatever SSRI works best for her. The middle 3 drugs, Zoloft, Paxil, and Luvox, are characterized by short half-lives, about 24 hours. Therefore, if one misses a dose or 2, you start into serotonin withdrawal syndrome. They inhibit the metabolism of other drugs and exhibit the same drug interactions that Prozac does. It's used in treating depression, dysthymia, and anxiety. So what's going to happen if 2 teenagers take off on a canoe trip up in the mountains, and they, of course, leave their meds at home? Well, one of the youngsters is on Prozac, gone a week, nothing's going to happen. He's not going into withdrawal syndrome. But the one who's on one of these 3 drugs is going to go into SSRI withdrawal and is going to get sick. So it can be a problem. Viibryd came out a couple years ago and was called a dual-action serotonin antidepressant. And this drug was an SSRI, and it's a partial agonist at serotonin 1 receptors. Compared with placebo, the drug's effective. It does not have any difference from other SSRIs on sexual experiences. Initially claimed to, but the FDA made them withdraw that claim. What's interesting is there has never been a comparison of Viibryd with another classic SSRI. So the drug is expensive, and it has unproven superiority. I really want to see a comparison of, say, Viibryd with Zoloft, but I have not seen that yet. And about a year ago, a little less than a year ago, Brintellix or vortioxetine was approved. This is called a multimodal serotonin antidepressant. And it has a mess of actions that you can see here. It blocks serotonin 3s, 5s, 1Ds. It's an agonist at 1A. It's a 1B partial agonist. Inhibits serotonin transporters. And it increases the level of several different transmitters. The problem here again is while the drug may be effective, there are no comparisons with an active SSRI. I'm not sure any manufacturer wants to take their new drug and compare it with a drug that is active because it might not look very good. Anyway, like all antidepressants, it increases neurogenesis. It may be effective. No comparison study of whether it's superior. It's not very effective in GAD. It's been claimed to reverse cognitive decline in patients with depression. It seems to be less effective than Cymbalta. So at this point, I don't see a tremendous need or use for this drug. Here's some reviews for you. That one I list in the first dotted point is downloadable free off of the internet. Go to pubmed.org, pubmed.gov, G-O-V, and just look up Ketona and vortioxetine, and the paper will come up, and you can download it free on that website. You can do a lot of that with these drugs on PubMed. More and more, you're able to download full text and get full copies of some of these papers. I remember when Celexa came out in the late 80s, and I said, why would that drug ever come out? It had been in Europe for quite a while. The patent was going to run out. The drug was effective for depression. effective for anxiety disorders. Half-life was nothing special, a little over a day. But the claim to fame was that the drug did not screw up the drugs, the three of them that I mentioned, plus fluoxetine, that inhibit drug metabolizing enzymes. And they promoted to physicians that Celexa, they didn't have to worry about this drug interaction with Celexa. So physicians prescribed it, and it became very, very popular. But the patent wore out. Well, manufacturers usually have some sort of a trick up their sleeve. And what they had here is that the active isomer of Celexa was S-citalopram. So instead of citalopram, the active isomer is S-citalopram. As you know, you look at a drug like amphetamine, it has two isomers, levoamphetamine, which is inactive, and dextroamphetamine, which is active. If you use 10 milligrams of amphetamine, you would use 5 milligrams of dextroamphetamine. Same thing here. Instead of 40 milligrams of citalopram, you would use 20 milligrams of S-citalopram. And once you make that dosage adjustment, they are absolutely identical drugs. The STAR-D study was about 8 or 9 years ago, and many papers on it. Just type in STAR-D in PubMed, and all the papers will come up, including the review papers. This is one from 2006, and it said if basically you put somebody on Celexa, 12 weeks, how many will get remission from their depression? I think it was a decrease in the HAM-D score to less than 12, I believe. And indeed, about 36% would. Placebo rate is about 25%. But in the patients not in remission, you do a switch to another SSRI, and you get a few more who remit. You switch to another drug, you get a few more. To another drug, you get a few more. And you find that if you put the patients through about a year of depression hell, you can get about 2/3 of the patient to remission. I think the lesson on this is how poorly these drugs work, especially in mild to moderate depression. Side effects. Everyone who deals in counseling, psychology, etc., needs to know that SSRIs can destroy marriages through sexual dysfunction. On every client visit, you need to ask the client, or more likely the spouse, about sexual desire and meeting the partner's sexual needs. We've gone through a lot of papers about adding Welbutrin or adding Viagra, and this may or may not help. Usually you end up having to come off of SSRI therapy. Then, of course, you have to deal with the withdrawal syndrome, and these patients can then be treated on a drug such as Welbutrin or non-pharmacologic mechanisms. Patients on SSRIs can exhibit a lot of sedation and also a lot of apathy, kind of flat faces. Their depression score may go down, but they really do better in society? Not necessarily. Sometimes a switch to a drug like Welbutrin, looking at other drugs for treatment of resistant depression. Abilify is widely advertised on television for this, and we'll talk more about that on Friday. Here's a list for you of other alternatives to drugs. There's about 10 or 12 of them here, and all of these are things that the patients need to do to have an improvement in their state of depression. You can't just give a drug and say, okay, everything is fine. We'll see that here in a few minutes in child and adolescent depression. Suicidality. Yes, especially in youngsters. Here's a reference from earlier this year in pediatrics. And it is an issue, and it's one has to be cognizant of. The major predictor of suicidality was anhedonia before drugs, and before drugs were administered, but one needs to be carefully treated, observed for that. Just a word on MAOIs. Powerful drugs back in the 50s. The problem was some patients dropped dead on them. And this is because they ate certain foods and beverages, got hypertensive crises, and either had a heart attack or blew an aneurysm in the brain. So physicians learned to hate these drugs and would not prescribe them. There's been a reissue of Marplan. It's interesting. I don't know if it's being used or not now. I haven't seen any sale figures. I doubt it's met with much use. In Canada, there is a reversible MAOI. It's not marketed in this country. In this country, back in '06, the MSAM skin patch came out. Selegiline was a drug from the Parkinson's armamentarium. The drug is robustly effective, very few days of onset, no sexual dysfunction. And I've had people tell me these patients don't get better, they're cured. Don't hold me to that, but it's probably the single most effective antidepressant we have. The question is, will they have adverse hypertensive reactions? This was the first paper done by Amsterdam, and he said in a year-long study there were no adverse hypertensive reactions. It's a very underutilized drug. If one doesn't want to use this 6 milligram patch every day, why not put it on and leave it on for 2 days? And that way you'll cut the cost in half, and you should cut the blood level down, and this would help any possibility of hypertensive reactions. It's a very, very interesting drug. I encourage your students to do some research on this drug and report it to the class. Okay, dual action drugs. We've talked about most of these, or some of them anyway, Effexor and the tricyclics. Prestig we talked about. Cymbalta, widely advertised. It is a norepinephrine and serotonin reuptake inhibitor. It's antidepressant. It's anti-anxiety. And because of the norepinephrine activity, the drug is analgesic. So again, it can replace a tricyclic antidepressant as part of this analgesic armamentarium we talked about. Remeron is less prescribed, but the drug is a stimulant of serotonin 1 receptors, and it blocks serotonin 2s and 3s. There's a lot of histamine blockade, so it's very sedating, and it can increase appetite and body weight. In most persons, this tends to limit the use of the drug. If someone wants to gain weight, wants to have an increased appetite and better sleep, it would be a good choice. Otherwise, probably not. Reboxetine is a norepinephrine reuptake inhibitor. Was not marketed in this country, but it improves psychological well-being and was shown to be a cognitive enhancer, probably independent of its antidepressant effect. In this country, we got atomoxetine, which is Strattera for ADHD. Its analgesic effects make it effective in conditions like fibromyalgia. The drug's antidepressant, anxiolytic, and analgesic. Because it doesn't have a serotonin action, it is probably significantly less effective in treating depression than other antidepressants. However, in someone with a pain syndrome, it's not a bad choice of an analgesic and antidepressant drug. We only have one specific stimulant of serotonin 1 receptors, and that's Buspar. The problem with it is you don't absorb it very well. you really have to take the drug in combination with an SSRI to be really effective. If you take it with grapefruit juice, there's something in grapefruit juice that inhibits an enzyme that causes first-pass metabolism of Buspar, and you can get a higher blood level of Buspar and improved efficacy. I keep hoping we'll see more serotonin 1A agonists. And we've talked about the other new drugs. Well, to kind of wrap this up in 5 minutes or so, I want to look at the treatment of depression in children and adolescents. It's a bad disease, a terrible disorder. It's said to affect about 11% of U.S. adolescents by age of 18 years, and about 40% of depression goes untreated. So it's a very common, very poorly treated disorder. Adolescence is the highest period of risk for the treatment of depression. It persists into adult life, and it does all sorts of bad things to interpersonal relationships, substance abuse, early pregnancy, low educational attainment, poor occupational functioning, etc. It needs to be better treated. The soft tab, and your students can look up soft tab on PubMed and pull these papers up. It discusses the treatment of depression, and indeed most individuals recover over about a 5-year period, 69% at 1 year, 90% by the end of 2 years. I think I have one more slide on this. But there is a high recurrence rate, 50%, 57% of females, 33% of males. It's argued that you should maintain contact even after one recovers to detect recurrences and educate on the expected course of depression. These people are at risk of everything from drug abuse to suicide, et cetera, et cetera. And interesting set of papers to read. Well, how do you treat this? There basically are 2 FDA-approved drugs, Fluoxetine and Citalopram. I don't think Citalopram is very good. I think there's a slide here. So as far as I'm concerned, Fluoxetine is the only SSRI that's really effective in treating adolescent depression. You can augment or use as a classic drug, drugs like Abilify or Lamictal, and these are appropriate. Now, there's a paper that came out about 2 or 3 weeks ago. I'm going to give you the reference, and there's an editorial with it. But this is a paper by Richardson, and it was in JAMA, and the date on that was August 27th, 2014, volume 312, and pages 809 to 816. So again, it's JAMA, August 27th of this year. And it's titled, A Practical and Effective Primary Care Intervention for Treating Adolescent Depression. Very good paper. It's the most recent one I can find for you. As you know, our textbook attempts to be the most up-to-date, but there's no way I can put an article from 2 weeks ago into the current stuff that you have on your shelf. So I bring this to your attention. This is a place for your students to start in talking about the collaborative interaction of medication plus psychological treatment. But this is a paper from '07. It's one of the later ones of the TADS study, Treatment of Adolescent Depression Study. And it said in moderate to severe depression, Prozac, alone or with CBT, accelerates positive response about 6 weeks earlier than with just CBT or placebo. If you're on medication alone, you're most likely to report suicidal ideation. combination therapy produces the most rapid recovery with protection against suicidal ideation. So here it is back in '07. This new paper that just came out in JAMA basically would be consistent with this. We need school-based programs to screen adolescents from 12 to 18, but you have to have a system to corroborate the diagnosis and to provide psychotherapy, CBT being the classic. They said at that time the evidence was insufficient to warrant a recommendation to treat younger children from first grade on for major depression. I think that should be reevaluated. There's now a large literature even on preschool depression, and that is an important thing to look at. It does occur in preschool children, and to me, I fully believe that actually depression probably begins shortly after conception in mothers who have depression. And the mothers that have depression have BDNF deficiency and problems with that. And so the child is born prone to depression, and it can exhibit in the preschool era. We'll talk Friday about Abilify and Seroquel as antidepressant, and these are approved for treatment-resistant depression. This is a table from our textbook on Abilify, looking at the numbers of patients who get minimal response versus partial, moderate, and robust. You can get some help. Geodon the same way, or excuse me, can do the same thing. Omega-3 fatty acids should be administered to children for brain development and also as possible antidepressant. The ketamine story is a difficult one. Ketamine has to be given IV, and so therefore its antidepressant action is of very short duration. Cyanidine or agomelanine can be antidepressant. And with that, a brief run-through of our slides. I leave us just a few minutes for questions, and I will turn this back to Elizabeth and see if she has anything for me. I hope this presentation introduces you to Chapter 12 in our textbook, gives an overview of what's in that chapter, and I try and point out some important things for all people in mental health to be aware of in their clients. So I thank you very much for attending. I look forward to Wednesday on anticonvulsants and their off-label uses, and Friday to atypical antipsychotics and all their off-label uses. Okay, Elizabeth,
thank you, Dr. Julien. That was great. Thank you. There are a couple questions coming in. The first one that I see here is someone said, what about ketamine? I'm going to go ahead and take everyone off of mute because the couple questions that I'm seeing, I'm guessing there might be some follow-up if that's okay. So that's the first one, but I'm going to go ahead and unmute everyone in case they want to ask some follow-up questions. So everyone is no longer on mute. If someone wants to ask a follow-up question to that, they can.
Before I go to bed, I'm going to take a look at this, and I'm going to plan accordingly before my 11 o'clock appointment.
I'm getting a lot of interference there.
Okay, so I'm going to unmute the person who asked that question and see if they want to ask a follow-up question here really quickly.
Okay. I'm going to try and answer that in a teaching mode. Ketamine can be demonstrated to be quite powerfully antidepressant. Okay, can you see this blue screen in front of me that says PubMed? Elizabeth,
yes.
Does that?
Yes.
Okay. Show you what, this is what we do with a fairly straightforward question like that. Go to www.pubmed.gov, and on the search line, I typed in ketamine. Here's a big drop-down list of their topics. I'm going to click on ketamine and depression. There's now 1,000 papers that have the word ketamine and depression in the title or the abstract. Now let's just take a look at a couple of these for the heck of it. Drug effects of ketamine, and notice I'm clicking in a box. Actually, I'm just doing this, I'm not really looking at what I want. I'm just going to click on 3 or 4, just for it. Now, notice I click some boxes. Let's say these are titles that you thought looked interesting. Click on Display Settings. Click on Abstract. Click on Apply. And now I've taken those articles that kind of looked interesting, and all of a sudden, here comes up not only the literature reference, but also the abstract of the papers. And none of those that I clicked had a full text. I want to find one if I can. Here's one. Here's an abstract. And notice that this was in JPET in this month's issue. And notice that this says free full text. So I'm click on that article. Let's see what comes up. And bingo, there it is. There's the full text. And you can do this on a lot of articles. So you'll find that going to this, if you get nothing more out of this hour than how to use PubMed, you've made a really huge step. You can type in anything here. Let's type in BDNF, brain-derived neurotropic factor, and depression. And it brings up 1,700 papers. So now to narrow that down, I'm typing in and review, because I only want the review papers, not the teaching papers. And here, all of a sudden, we narrowed that down to 300 papers. You could go, you could narrow it by and human. Let's see if there's anything. 304. These are all review papers. Here's an interesting looking paper, Neurotropins and Psychiatric Disorders. BDNF and synaptic plasticity, cognitive functioning and dysfunctioning. Looks fascinating. Display function, abstract, click. There we are. And there's the abstracts, and then you can go get the paper if you like. Other things you can find on this, you'll notice over here on BDNF, depression, human, and review, there's 51 free full-text articles in PubMed Central dealing with this topic. And here I'm clicking on see all 51 of them, and here are 51 papers that you can download full text discussing the etiology of the neurogenesis of depression. Probably the single most powerful tool you can have in your teaching. So I didn't really answer your ketamine question. Powerfully antidepressant. Problem is it's short duration. The drug has to be given IV. And the problem is how do we get this glutaminergic stimulation in something that would be practical therapeutically on a day-to-day basis.
Great, thank you. I know that we are getting close to the end of time here, so I just want to make sure everyone knows where the recordings are going to be, along with the other information in terms of getting credit. So thank you again for that, Dr. Julien.
Thank you.
Okay, so I know there are, like I said, a couple questions about where the information is going to come from. We're going to go ahead and send out the questionnaire after this is over. In terms of where you can get the information after this webinar and the following ones this week, you can go to Faculty Lounge. The website is at the bottom here, and the recordings will be posted there, as well as sent to you with the PowerPoint slides. And we also have a Twitter page if you would like to follow and find out information on future webinars. So I wanted to let everyone know that you have that information there as well.
If I'm there.
Go ahead. Yep.
If I'm there, I might also mention you can email me at DRS for doctors, DRSJULIEN at Comcast.net. And it may take me a day or so to get back to you, but I will do that. DRSJulien at Comcast.net.
Thank you again, Dr. Julien. I know we're out of time, but hopefully everyone will be able to join us on Wednesday and Friday as well.
Thank you.